Again, hello everyone, we came back with another different video with the same energy with different topics. Our today's topic is typhoid fever. So let's have some brief discussion about typhoid fever, and you will read from the textbook. That's what the teacher says. So let's start from the typhoid fever. What is typhoid fever and what is the microorganisms that can cause the typhoid fever? The most common and well identified microorganism that studied for the causative agent of typhoid fever is Salmonella Typhi. Salmonella Typhi is the most famous and known type of organisms natural, and human is only reservoir. Human is only reservoir. That means it only infects human beings, not zoonotic type of infections, and it is grouped under gram-negative group of microorganisms. So how it transmits? Transmission. Usually, typhoid fever is a disease of developing country. It transmitted with fecal-oral transmission, so it is hygiene related. Fecal-oral. Its route of transmission is fecal-oral transmissions, or for the man who have poor hygiene. But in some cases, some individuals could have presented with the clinical form called chronic typhoid fever. Chronic typhoid fever. Later on, we'll discuss about it. In the case of chronic typhoid fever, usually it comes not from the poor hygiene, rather maybe initially acquired by fecal-oral route, but the chronic typhoid fever is usually the source is gallstone or gallbladder. The source is gallbladder is the source. So let's see about some epidemiology of the typhoid fevers. So currently, typhoid fever is a global burden, especially for countries who found this in developing countries like Africa and South Asia. It is the most predominant type of the cases. Just annually, about 9 up to 27 million cases per year will be identified because of this typhoid fever. So it is a global burden. It affects many individuals. So what are the risk factors for acquisition of this typhoid fever? As I mentioned before, the first one is poor hygiene. The other one is travel to endemic area. This works for patients who came from the developed nations. The other one is young age, especially it is most prevalent between 5 up to 15 years. This is the most common type of age on nature. And the last one is low BMI. For individuals who have underweight are susceptible for developing this typhoid fevers now. So typhoid fever, how it causes disease, or what is the pathogenesis, the pathophysiology behind this typhoid fever. So let us see the pathophysiology. So generally, initially there is an ingestion. As I mentioned before, it is fecal-oral transmission. So there must be an ingestion of the microorganisms from the contaminated either food or something. So when this ingestion, the microorganisms will descend into the intestines. The intestines means it survives the acidic environment. After it survives the acidic environment in gastric, it will descend into the intestine. It will descend into the intestines, and it will invade the distal ileum. Invade the distal ileum. What we have in the distal? What immunologic components do you remember in the distal ileum? It is a Peyer's patch. So in the Peyer's patches, there are cellular component called M cells. M cells are the most critical important points. M cells are being invaded. Normally, let me show you here. Normally, these are the enterocytes. This is a nucleus, and there is also another enterocytes. So there are special type of cells that extend their limbs here in the intestinal. So these are called M cells. Their main role is they collect antigens from the intestinal lumen, and they report to the macrophages or the immune cells. Cells. So the same works here. The Salmonella Typhi communicates the M cells in the microfold cells, or they are called a microfold cells. microfoil cells in the pyrus patch. Pyrus patch, it is like a malt. It is mucocyte associated lymph nodes. Mucocyte also associated lymph nodes. So the next step is there will be phagocytes by what? The next step is there will be phagocytes by macrophages. Phagocytosis. But the Salmonella Typhi or these microorganisms will not die inside the macrophages because it has its own survival mechanisms. These are because of two things. The first one is there is a polysaccharide coverage around the microorganisms, cell membrane, polysaccharide. And the other one is there is a type 3 secretion system. So these are the two important things. So what is type 3 secretion system? We will discuss it in the next video. In the case of Shigella, we will discuss it in detail how it works. But just to give you a general concept, normally the microorganisms or this Salmonella Typhi has a spikes on his membranes and it will attach to the lysosomes. So what? When after they are ingested with the macrophage, initially the next step will be the formation of phagolysosomes. That means the phagocytes microorganisms is again phagocytes by the lysosomes, and there will be essential proteins and chemicals that basically can kill the microorganism inside the lysosome. But what they do is, because of the type C secretions, there is a spikes that attached to the lysosomes membranes. The lysosome will degrade. When the lysosomes degrade, the intralysosomal component released into the cytoplasm. So the microorganisms that can comfortably survive into inside the cytoplasms, and they can multiply by themselves. So there is a multiplication will happen. So usually the most common site to be multiplied for Salmonella typhus are these reticuloendothelial systems. Endothelial systems, and the most common mentioned reticuloendothelial systems are the liver, the spleen, the bone marrow, and the lymph nodes. These are the most famously known reticuloendothelial systems, and they are favorable ones for the replications of Salmonella Typhi. Then after it's replicated, then the last one is there will be secondary bacteria from the bacteria. There will be a secondary bacteria. Then finally systemic manifestation will happen. So the systemic manifestation happen because of two things. The first one is when there is over replications, especially in the case of pyrus patches. When there is over stimulations, there will be hyperplasia of the pyrus patch. And the other one is immune systems, as a body will be initiated again. Immune response, antibodies will be formed, T cells will come and they will attack the immune systems. So this hyperplasia of pyrus patch basically cause two important things. The first one is these immune actions can cause a necrosis around its environments, and an ulceration can be resulted. Then later on the patient may risk of perforation will be high. Risk of perforation is high. Usually this happen in the second and in the third week of Salmonella Typhi infection. So what are the clinical manifestations of this Salmonella Typhi? So let's group the Salmonella Typhi clinical manifestations into 3 weeks. The first one is in the case of week 1. In the case of week 1, it is called invasion phase. Initially the microorganism was attached into the pyrus patch and tried to replicate itself in order to form many or systemic bacteria. That is a weak one. It is called invasive phase. At this phase, the patient has experienced a fever, but the fever pattern is totally different from other form of microorganisms. In the case of Salmonella Typhi, it has a step ladder type of fever. Step ladders. This means that, for example, in the case of malaria, it has intermittent fever, means that in the some part of the day the fever spikes high, and in some part of the day the fever returns to its normal ranges. But in the case of Salmonella Typhi or typhoid fever, the fever will not come or will not decrease in times, rather step ladder. It gradually increased in times. For example, if it is initially 38 degrees centigrade, later on it becomes 39 degrees centigrade. So it gradually increased in times. But otherwise, associated systemic manifestation can happen, like arthralgia, myalgia, headache can be happens. And the most interesting part of this is, since it is fake oral transmissions, there is diarrhea or constipation. Which one do you expect this? So in the case of Salmonella Typhi, constipation is the most common clinical presentation you can find this, rather than the diarrhea. So constipation is the most common. Constipation is greater than diarrhea. So these are the clinical factors that you can see in the case of UCAN at the Salmonella Typhi infections. So what are in the week 2? In the case of week 2, it is establish the disease. It establish the disease. So the fever sustainable type of fever will be existed if left untreated. The other most important is there may be a development of rose spots. These rose spots usually markedly seen in white individuals, but in the people like me, like dark skin, they may be difficult to appreciate. But their characteristics, they are characterized by faint and blanching maculopapular rash. Blanching maculopapular rash. They are a blanching maculopapular type of rash could have seen in the patient. It's usually prevalent in 10 up to 30% of the individual. 10 up to 30% of individuals can have this. So the last one is, it is the week 3. This is the peak complication of the Salmonella Typhi happened here in the case of week 3. The first one is, if left untreated, the patient could have experienced what? Perforation, pneumonia. It is a systemic manifestation. Neurologic symptoms and mucocutaneous symptoms can be happened in these cases. So what are the most commonly stated complications in the case of Salmonella Typhi? As I mentioned, the first one is intestinal perforation. Perforations. In the intestinal perforation, usually researchers indicate it is more common in the 3rd and in the 4th week of the cases. And systemic wise, the systemic wise complications, as I mentioned, they have septic manifestation, neurological manifestations, sepsis. They could have shock, even they could have in case of shocks, and they could have these neurologic manifestations. And the mortality or when you see about the prognosis, mortality from the Salmonella Typhi with appropriate treatment, it is less than 1%. It is the most treatable type of microorganisms. So how do you diagnose and how do you manage will be our next topic. So the diagnosis. The diagnosis is basically, it is time dependent. For example, in the first times, like in the case of week 1 in invasive stage, usually it is better to diagnose the gold standard diagnosis for the week 1 cases. Week 1 is, the first one is, it is blood culture. The other one is, it is bone marrow culture. In the case of blood culture, we have a high about sensitivity of 60 up to 80%. This is true for the week 1. But if you do blood culture in the second weeks, the sensitivity and specificity decreased. And the bone marrow culture also another most important and sensitivity, because it is one of the reticuloendothelial systems. Despite the patient is on antibiotics, the sensitivity of this bone marrow or the specificity of the sensitivity of bone marrow, it is about up to 80 to 90%. So if you suspect Salmonella Typhi and you want to try a culture, it is better to take from the bone marrow. And on week 2 and 3, clinically, the most sites for culture is, it is stool culture, because there is hyperplasia of the pyrus patches and releasing of these abundant microorganisms into the bowel. So the pyrus patch will be release a lot of the Salmonella Typhi. So stool culture will be the most sensitive ones in this case. The other one is, it is serologic examination. This is for culture. It is culture. The other one is, it is serologic examination. When you say about serologic examination, the famous one we do is, it is Widal test. We have two types, Widal test O and Widal test HS. Their sensitivity is region dependent. For a patient with endemic areas like here developing country like in the South Asia and Africa, endemic area, sensitivity and specificity is low. Sensitivity is specificity is low. So usually we are using some for non-endemic area. So finally, how do you manage Salmonella typhi or typhoid fever? So we have two groups. Here we have two groups. The first one is susceptible groups, and the other one is it is multi-drug resistance, and sometimes we have extreme drug resistances. For susceptible groups, fluoroquinos, it is basically the most good one. Fluoroquinos are the most good one, like ciprofloxacin. 100 milligram POBID, we can treat it for 7 up to 10 days. We can treat for Salmonella typhi. But for multi-drug resistance or extremely drug resistance, so first of all, when do you say the microorganism is multi-drug resistance? If the microorganisms has resistance to ampicillin or chloramphenicol or cotrimoxazole, you can abbreviate like ACC. If it has resistance to this one of it, like ampicillin or chloramphenicol or cotrimoxazole, it is basically resistance. But if the microorganisms, this multi-drug resistance plus resistance to fluoroquinones like ceftriaxones and third generation cephalosporins like ceftriaxones, here ciprofloxacin fluoroclines, if the microorganisms is resistance one of it plus these ones, we will say it is XDR or extremely drug resistance Salmonella typhi or microorganisms, like we can say that. So how do you manage these patients as MDRs? So for suspected MDR and XDR microorganisms, the first choice of antibiotic is ceftriaxone. For MDR, we are treating them with ceftriaxone 1 gram IV BID plus azithromycin. Azithromycin will be the choices. For severe case, like in the case of encephalopathy, in the case of perforation, in the case of shock, or like the type of the complication we mentioned here, if one of them happens, we have to make the antibiotics ceftriaxone plus carbapinium. This one is just for MDR. This one is MDR with complication. Carbapinium like meropiniums or imipiniums can be the management choices. But if the microorganism is XDR, it means it is extremely drug resistance, we need to change the microorganism. So we are going to treat them, these XDRs, with azithromycin for 1 week plus carbapinium. Carbapiniums will be the management choices for these microorganisms. And the last one is for chronic typhoid fever. As I mentioned before here, the usual treatment modality is ciprofloxacin for up to 6 weeks plus or minus cholecystectomy, because usually these patients, as I say, the source for chronic typhoid fever is gallbladder. So cholecystectomy may be indication for the chronic typhoid fever patients. So this is all we got for today. Okay, sorry, the last one is prevention. How do you prevent this? It is one of the most preventable type of infectious disease. How do you prevent the Salmonella typhi? The first type of prevention is simple. Is hygiene. You need to keep yourself clean and hygiene. And the second one is there is a vaccination. Currently there are some prepared type of vaccines that are available in the market. The first one is bipolysaccharides, TY2, oral attenuated typhoid fevers, and the other one is TCV. These are the vaccines that currently available in the market. So finally, this is all we got. So subscribe my channels. Let's continue learning. Have a nice time, guys.